right, great. Looks like everybody has come in now. Welcome everybody to our event, the Transplant Center COVID Town Hall at Stanford Children's Health. Thank you all for joining us. My name is Josh Tassett. I'm the director of the Transplant Center at Packard, Lucille Packard Children's Hospital, and I'm going to be doing just a short welcome with you guys. And I have a quick message from one of our Spanish interpreters, Zoli, who will be giving some instruction briefly about any Spanish speakers that have joined that would like to access the interpretation feature. So, Zoli.
Sí. Hola, buenas tardes. Bienvenidos a todos a esta reunión. Para las personas que hablan español y necesitan un intérprete, en la parte de abajo de la pantalla van a ver un mundo. Si dan clic en ese icono, van a poder accesar el canal de español o al canal de inglés, si lo prefieren. Si apagan ese canal, entonces van a escuchar el lenguaje original. También en la parte de preguntas y respuestas pueden escribir su pregunta en español y uno de nosotros lo va a traducir al inglés. Y al final van a contestar las preguntas.
Okay, thank you for that. Appreciate it. So now we will get started with our program today. I'm going to pass it over to Dr. Rachel Benson, one of our liver transplant hepatologists, who will be serving as moderator for today's event. Dr. Benson?
Well, welcome everyone. We are very happy to have this event this afternoon to share some information with you about COVID, answer common questions, take some of your questions, and also just another opportunity to bring our transplant community together. We'll be starting off with some questions that were sent in by some families before the event, as well as common questions that were asked regularly by our patients in our visits. And then we'll move on to answer questions submitted in the Q&A. So please submit your questions through the Q&A function at the bottom. Because this is a webinar, everyone will automatically be muted. So yeah, please use the Q&A or chat functions. We also we'll be monitoring that, may type some answers to some questions in there. If you enter your questions in Spanish, our interpreters will translate them for us. So please feel free to enter them in English or in Spanish. And we will be recording the session to share information with you again later. We have a fantastic and highly experienced panel here with you. So I'll briefly introduce them. We have Dr. Haley Gans, one of our infectious disease specialists who focus on infectious diseases in immunocompromised children. Dr. Avanti Chowdhury, one of our kidney transplant doctors. Dr. Elizabeth Profita, one of our heart transplant doctors. Dr. Carol Conrad, one of our lung transplant doctors. And Lindsay Barkoff, one of our heart coordinators. So welcome everyone. Our first question that we'd like to begin with would be with our infectious disease, Dr. Gans. Okay, Dr. Gans, can you share with us how much COVID are we seeing now in our area? And are we seeing patients being hospitalized? And how are children doing?
Thank you for that question. And I just want to welcome all of our families and anyone else in the community who's joining us here today. We really encourage you to share your questions with us so we make sure that this webinar actually meets your needs. So I did want to just give you a graph because I know some people are very visual and hearing numbers isn't necessarily what is necessarily a focus. This is data just in children and adults. So this is data where you see the adult cases are in the light blue and you see the child cases, which are in the dark blue bars. And I think this represents a lot of what's happening in the pandemic. So children, as with adults, when the cases go up, they go up in both populations. And you can see that because you see a rise in both the color bars as things happen. What we know from the start of the pandemic, which is on the very left, we had a very large increase in the numbers during our winter months. That was our highest peak. And during that time, the children peaked, but what you'll see now very far on the right is that while cases are peaking again, they're actually peaking at a greater rate in our pediatric populations and not in our adult populations. And the reason why this is happening is manyfold. So we're seeing that people who receive the vaccine are protected from getting infected, and that's largely our adult population. And of course, we'll talk in a little bit more about pediatric vaccination opportunities, but to date, as people are very well aware, only those individuals who are 12 and older have had an opportunity to be vaccinated. So cases are going to be seen in those people who are susceptible or at risk for getting the disease. And right now that's in our children. We also know that our communities have opened up, and this graph that we're seeing here, while it's the US graph, has been mimicked in all of our communities. So our community also saw a rise that was similar to this. Early on in the pandemic, we actually had very few hospitalizations in our pediatric wards. And then we did have an increase in hospitalizations. Our highest hospitalization rates were during those winter months, but now we're actually seeing, again, a real boost in our hospitalizations. Since the beginning of the pandemic, so if you compare rates of both disease and hospitalization at the beginning of the pandemic to now, there's been about 100% increase in the rates of childhood cases as well as the rates of hospitalization. So more children are coming into the hospital, but more children are also getting infected. So it's a spectrum of disease. The good news in all of that is over this period of time, we've obviously learned to treat people who have active infection. And so the number of people who pass away from having the infection actually has dropped despite numbers going up. And we also have seen those same trends within our hospitalization.
Thank you so much, Dr. Gans. And how are transplant children doing with COVID infections, and in particular with the Delta variant?
Yeah, thank you for raising that. So I forgot to mention that obviously this virus, like all viruses, as they become more competent to infect an individual. So this virus jumped from a species into humans. And so at first it was not very well compatible with that infection. And so we do see with the original virus, it was not as able to infect humans as the Delta strain. So viruses do this all the time. Every virus that has jumped species does this. It learns to infect the host to a greater degree as it's allowed to replicate. So right now, our main strain is called the Delta strain. It's much more fit for humans, and so it's much more contagious. That means people can spread it more easily from person to person. So we are seeing what is considered an attack rate. Once one person is infected, their ability to affect other people is much higher. So the Delta variant has changed the virus and has changed how we get sick with it and how we transmit it. So that's definitely contributing to this new surge that we're seeing, because many of us are vaccinated if we're able to get that. So it should have brought it right down. And the fact that we're seeing an increase is really due to this new strain that's much more transmissible. So that includes children. It's more transmissible to children and from child to child. The other part about being more fit is it can cause more disease. So we are seeing more symptoms in our children as well. Whereas before, many children were infected and would incidentally get tested but had no symptoms. Now we are seeing children with symptoms simply because the virus is able to replicate in their bodies more efficiently. Our transplant population, luckily, those who received a solid organ transplant actually do not have higher rates of infection or disease severity than the general population, unless they have another predisposing condition that's highly associated with more severe disease to COVID. For instance, an increase in weight. So obesity is associated with that. So our transplant population who have that are at higher risks simply because of the other risk factors There are some other risk factors, for instance, neurologic complication, underlying neurologic. So if you have another risk factor, then you're at the same risk as other children who have that risk factor for acquiring more severe disease. So lung disease is one thing that obviously predisposes you.
Thank you very much. And thinking of another question that is unique to our transplant population, Dr. Profitec, can you speak to what kind of COVID screening is done for deceased organ donors prior to donation?
Yeah, it's a great question. I'll also touch on like what happens if the recipient is COVID positive. So we really don't want to take a COVID positive organ or a COVID positive patient to transplant because of all the immune suppression that you get at the time of transplant. So all donors for all organs are always screened for COVID infection, and we would not take an organ in any of our programs here at Stanford if the donor had active COVID infection. And then for our recipients, similarly, we would not want them to be dealing with active COVID infection as well. On the heart side, patients who have a positive COVID test, we require 6 weeks from a positive COVID test and retesting before we reactivate patients on the list. Again, we don't know exactly how patients would respond, but anticipate patients wouldn't do well to take an organ that was COVID positive. So we're trying very hard to avoid that. But with our testing, we've been very successful. We have not had any transmission of COVID from a donor that I'm aware of.
Thank you, that's really helpful. And what treatments are available for patients with liver transplant or heart or kidney or lung transplant if they do get COVID and are sick and symptomatic?
Sorry, was that one for me?
Sorry, yes, thank you.
Okay.
That one.
Okay, wonderful. So we do have a number of medications that we do use to try and help with active COVID disease. I will tell you that in general, viral illnesses are not something that we have really great medications for. So we do have a particular medication that is directed against the virus itself. Unfortunately, it's not like many of our other antivirals. It's not very effective later in the disease. So what we know about antivirals or medications against the virus is they're good early on. So we do use that so that we can help at least reduce the amount of virus that people are seeing. We also will use, surprisingly, because I know this seems a little counter to people, other medications that help decrease your immune response to this virus. So like every other infection you get, it's actually not the infection itself that gives you the symptoms, it's your immune response. And then that immune response can actually lead to, so the symptoms you see like fever and muscle aches and headache and other things like that are actually your body's response. All these chemicals are released in order to fight the infection, but also cause these other symptoms. And as well as tissue damage. So the tissue damage, there can be some direct damage from the virus itself, but it's actually the immune response, which it's targeted at the tissue, that actually causes most of the destruction. So we have another medication that's directed at helping decrease that immune response. Now, this is a little controversial, obvious, and people are already immunosuppressed, so those people who are on other medications, but we do kind of balance all that when we have individuals come in. And then there's other therapies that we can use to treat people who are hospitalized. One effective therapy that we have been using. So if you're exposed or you have mild symptoms, you don't need to come into the hospital. One of the most effective things we can do to you is give you what's called monoclonal antibodies. And this is a collection, this is a manufactured antibody. So part of your immune system is an antibody response. And these are directed against the virus itself. It doesn't clear the virus from your body because antibodies don't do that, but it does help it stop spread from cell to cell. So we can give that. Unfortunately, it's restricted at this moment to children greater than 12 years of age and greater than 40 kilograms. So that is effective for those individuals.
Great. And thinking of patients or family members who could potentially be testing positive, what are the current visitation guidelines at the hospital? Dr. Chaudhry.
Thank you, Rachel. So, of course, the guidelines keep on changing a little bit depending on what's going on in the community and what the current public health California guidelines are. But I'll tell you what the current guidelines are. For any patient who needs to be either admitted to the hospital or having a surgery, their parent or a caregiver will need to have a proof of vaccination, proof of full vaccination. And that's at least 10 days from the last dose, depending on which vaccine you're getting. If you don't have that, then the parent would need a proof of a negative COVID test within the 72 hours. Now, RT-PCR is the best, it's the most accurate COVID testing, but that takes some time. So antigen testing is also okay. But these are one of these two is required to be with the patient. Now, if a child needs to be admitted and the parent doesn't have that, we will still admit the child, and of course we'll look after the child. And if it's the first time, the parent can come in with the child, but will not be allowed to go out of the treatment room or the patient room. And if they go out of the hospital, they have to come back in again. And before they come back in again, they have to provide either the proof of vaccination or the proof of negative COVID test. No other visitors are allowed. But I just have to say that this is just for inpatient admission and surgery. So if a patient needs to get into the lab or clinics or radiology and or infusion center, they can come in without these proofs, but they just have to be with the patient and leave the hospital just as the appointment is over.
Thank you. I think for all of our families, it's just always check in before you're coming in, what the guidelines are, and know that there can be, it's always a moving target as we're doing our best to keep everyone safe and healthy all throughout the hospital. So now I wanted to shift a little bit to some questions about vaccines in our transplant population. This question was also brought up by somebody already during this webinar today, but how effective is the COVID vaccine in children on immunosuppression? Dr. Gans, if you can speak to that for us.
Yeah, of course. It's a great question. We actually wish we knew more about that in pediatrics, but what I will tell you, a couple of points that we consider when we're thinking about vaccination in our immunocompromised children. There's been a number of studies that have been done in adult immunocompromised, so those who have received transplants on the adult side. And those studies have shown that after 2 vaccines, so the messenger RNA vaccines, the ones that are indicated for children right now, are given at 2 doses. So that's the series that was authorized. After these 2 doses, when you measure the response in adult transplant patients, then it's actually lower than in the general population. Even when you take normal immunocompetent or people who don't have a compromised immune system in the same studies, they actually do better. So it's anywhere from 50 to 70% of individuals in the immunocompromised group or the solid organ groups compared to in the 90s in those people who haven't undergone a transplant. So it's significantly lower. But numbers aren't everything. And so what some of these studies have also done is look to see how good this response is at actually neutralizing or making the virus not able to replicate. And that showed actually a dramatically low response, even in those transplant individuals who were able to make a number that looked good, their function wasn't that great. And so then the follow-up study to that was they gave them a third dose as part of a series. And that third dose really actually increased not only the numbers that we saw, but also the function. So it was actually a very good strategy for helping those whose immune systems were a little bit suppressed to actually come into a range that has been shown to be protective in people whose immune systems are not suppressed. So it's a highly effective strategy. It's actually the way many of our previous vaccines are used. There's not many vaccines actually that are given in this 2-dose schedule so close together. That's usually what we call a priming. So you do something that you tell the immune system to look at this new antigen or pathogen, and then you prime the immune system to respond to it. It often needs a prime boost. And that's what this strategy is. It's priming your immune system to then be able to be boosted into a place where you have good function. So in children, what we know is that the solid organ transplant children actually have lower responses to many of the vaccines that we give them. We already know that. And so the presumption is they will have lower responses also to this vaccine because its mechanism is the same. In some of the studies that have been done, the preliminary data is to suggest that they do have lower immune responses and lower functionality than the general pediatric population. So we do think this is a very highly effective strategy for our population.
And someone brought up a great question here in our Q&A. So are we here at Stanford doing any study of this? And the answer is yes, we are. I don't know, Dr. Gans, if you want to speak very briefly to our research study.
Thank you. So we are doing a study. We are looking at both those antibody responses, both the function and the number, as well as what we call a T cell study. So you have 2 arms to your immune system. T cells are really, really important. And what we understand are really helpful for you keeping onto your immune system, but also clearing the virus. So our study is slightly unique to those that have been done around the country. So we hope to add really great information to what is known about this virus and a pediatric response. We're going to do it in all of our solid organ transplants, but also our other immunocompromised host groups. So we hope to get really great data to you all at some point soon.
And if someone is interested in enrolling here, sorry, Dr. Puff.
Oh, no, I was just going to say, but at this point, we aren't routinely testing patients that are not enrolled in the study for their antibody levels. And I'm sure Dr. Gans can speak to this, but because we don't know what to make of them yet, because the research hasn't been done. So at this point, we would still recommend that all solid organ transplant patients receive 3 doses of an mRNA vaccine, which is like the Pfizer for the under 18, and without doing any testing, because we don't know what the numbers mean yet. We're still studying it.
Absolutely. I couldn't agree more. And in general, we don't know what's considered a protective level. So just as Dr. Profeta said, we're looking at that. We're trying to understand that. We have some data now in adults about breakthrough, but we don't have that in children. So those who have been vaccinated and then get disease, we need to go back and look at their antibody responses. We're going to have that availability to do that in our study because we are following those. If you are interested in enrolling, please contact your transplant team and they can get in touch with us.
Exactly. That's all I was going to say. We can talk to your transplant team because your coordinator can help connect you with the study and let you know what it entails. And so our next big vaccine question is, how safe is the vaccine for kids? What are common side effects of the vaccine?
I think that's for me.
I think that is for you again.
Okay, thank you. Another great question, because anytime something new comes on the market, we need to really understand it and make sure that the benefit and the risks weigh in benefit. This particular vaccine, the vaccine that is licensed for use in children, is highly effective, as we just talked about. I mean, you need the through doses. The safety profile in all children actually is very good. One thing that people should understand about this vaccine is that these are some of the most highly studied. So even the clinical trials that actually were what the authorization was based on were some of the largest vaccine studies that we've ever had. So even in those preliminary data sets, the numbers were incredible. Since that time, as everyone knows, we're in a global pandemic. So this is a vaccine that's used globally. Billions of doses have been administered. And what's really amazing is that we actually have real-time data on all of the adverse reactions to this. So what we do know is in the studies, and people have sort of done sort of follow-up studies, there are some local reactions to this. It does make your immune system, again, as I said, it's your immune system that gives you those clinical symptoms. So your immune system does see it and respond to it, which is great. So you do have some of that locally, but overall, this is highly safe. Some of the common side effects are sort of what you would expect if your immune system was revved up. So you'll have some pain where you got the vaccine. You might have a headache, you might have body aches, you might have fever. All of those are pretty common after this, just showing how much it actually does make your immune system respond. But that's kind of what we want. And just to let you know the difference between getting an immune response from a vaccine and getting the actual disease. When the disease goes into your body and you allow that viral replication, as we talked about before, your tissues get infected, and there could be, well, we don't know about this, there could be long-lasting effects of that. When you get the vaccine, you don't get that viral replication, of course, and so you don't get that tissue part of it. You might get all these other very transient effects of the vaccine. So we're monitoring it. We monitor it for about 13 severe adverse reactions in real time, and we haven't really seen signals, particularly in children, except for, I think, what's going to be discussed in a minute is the myositis.
I think that, again, led directly right into Dr. Profita. Can you tell us a little bit more about vaccine-associated myocarditis and the risk in our patients, especially those of our transplant patients, either who have heart transplants or have had other organ transplants, but may have some heart conditions?
Yeah, great question. I'll start by just explaining what myocarditis is. So myocarditis is an inflammation of the heart muscle that can present with a decrease in the function or the squeeze of the heart. And it's typically caused by common viruses that we see. We don't know why in some people it can affect the heart, but a common virus can infect the heart and lead to damage that sometimes can be severe and other times can be very, very mild. So that's what myocarditis is. And after we started vaccinating patients across the world, we started to see that there was concern for the development of myocarditis after the vaccine. This was initially found in Israel and then in the US military, and it seems to be predominantly in younger males. And what was happening was that typically after the second dose of the mRNA vaccine, so both the Pfizer and the Moderna, we were seeing patients presenting with some chest pain, typically just a few days after the second dose. When they were evaluated, they were found to almost always have a normal squeeze of the heart. So the heart squeeze was normal, but they did have an elevation of the cardiac enzymes, troponin, which is sometimes elevated in signs of heart injury or swelling. And the EKGs, the rhythm of the heart, was sometimes a little unusual, but often normal as well. And the big finding was that there was cardiac MRI findings that were consistent with what we see in a typical myocarditis. So we call this vaccine-associated myocarditis, and it is a little bit different than the true myocarditis. While it looks a little similar on MRI, which is how it's gotten this name, it doesn't seem to be acting the same. And so what we know about this thus far, it's still evolving. It's a very rare side effect, and we know a lot about this because we are continually tracking what's happening after vaccinations through national registries and databases, and the CDC and FDA is continually reviewing all of the data. And so what we know is that in the over 12 population, there is an increased signal of an increased rate of myocarditis, particularly in adolescent and young adult males, of this vaccine-associated myocarditis. I have seen almost all of our patients here at Stanford who have come in for that complication, and I've been following them since this has happened as well. And the vast majority have had complete resolution of those MRI findings at 3 months. And the troponin levels normalized. And as I mentioned, almost all of them had totally normal squeeze of the heart to begin with. So we don't think that this is a long-term consequence, and we think this is a short-term finding. The chest pain seems to resolve within a day or two. And so our best thought about this is that this is an inflammation of the heart that is happening not because of virus, but because your body's making such a strong immune response to the vaccine with that second dose. And we know that the COVID virus can infect the heart, and you can get much worse heart disease if you get COVID, because COVID can cause true myocarditis from the viral infection. And MISC, the multi-inflammatory system disorder in children, also can affect the heart and the blood vessels. So we know this virus can affect the heart. So we think that this is just sort of this transient inflammation that you're getting from such a strong, robust immune response from the vaccine. We have only seen this complication in children who are otherwise healthy. We have not seen this in any patients that have had solid organ transplant, to my understanding, with talking with colleagues across the country. And so I do not think that solid organ transplant patients are at increased risk, or other patients who've had heart disease before. And we don't think it's necessarily a genetic risk either. We're not necessarily seeing it in families as well. So at this point, again, it's very rare. We still are strongly recommending vaccines for all of our solid organ transplant patients. And again, we're still recommending 3 doses of the mRNA vaccines for solid organ transplant patients due to the decrease in the antibodies that we think patients develop as related to the immunosuppression medications that they're on.
Thank you. On the subject of getting all of our COVID vaccines this fall, Dr. Conrad, can you speak to the timing with COVID vaccine and flu vaccine? Do they need to be separated?
That is a very good question, as all of us are going to implore our patients to become vaccinated to both. And there is no reason to separate the timing of the two. A strong response to one doesn't inhibit a response to the other, and vice versa. So please, if you're going to go out and get vaccinated, get them both.
Thank you. That is great. And what is the timing for getting the 3rd dose after the 2nd dose?
Are you asking me?
I am asking Dr. Gans.
Thank you for that. Anyway, you can get it anytime 1 month after you've received that 2nd dose. So
thank you. That was a question from one of our families, but that's a great question that comes up a lot.
It does, yeah.
And 4 weeks from
we
the 2nd dose.
We may have some FAQs that have some of this information for you, but I would say your best resource is your transplant care team. They know all the answers. So I would.
When we don't know the answer, we ask you.
I do want to make a plug now that we're talking about flu and COVID, to suggest that another way that we can protect children until they're able to do this is for all family members to get their COVID and flu. We're seeing a lot of transmission, unfortunately, from our unvaccinated adult population to our children. And really the best thing we can do to protect our children, because they don't have that opportunity yet. We can talk about that in a minute, but please, please, please help protect our children by getting all people who are 12 and older vaccinated in your household, and get everyone the flu shot. Obviously, they can have that.
And a similar subject, if a family member or a child has already had a COVID infection, does he or she still need a vaccine, Dr. Chaudhry?
Yes, definitely. And the question frequently comes up when, because that has changed a little bit over the course of this pandemic. So firstly, when you get an infection, you are most likely to develop some antibodies, but we don't know how much, what level, and how long they last. So how robust the protection is against infection. So it is definitely recommended that you do get the vaccine. And the current recommendations are that you can get the vaccine as soon as you recover from the illness, like you're symptom-free. You don't have to wait for any length of time. If anybody's wondering why we had this, we used to say that you have to wait 90 days after the infection. That is because we didn't have such a big vaccine stock, and we just wanted to make everybody vaccinated, and people who had the disease were protected somewhat. But that's not the case anymore, and so the recommendation is to go ahead and get vaccinated as soon as you're symptom-free, unless you have had some special treatment with monoclonal antibodies. In that case, obviously, your transplant team will ask you to wait for 90 days. But other than that, pretty much straight away.
Thank you. And we kind of hinted at this a moment ago, but Dr. Gans, can you speak a little bit to the timeline for when we think vaccines will be available for kids who are under 12?
Yeah, well, we know we're all waiting for this very eagerly. So I have the opportunity to actually sit on the FDA panel. And so we have had the data submitted to the committee. We're under review right now, and we have a meeting October 26th to discuss the data. And it's after this meeting that we'll know if the data was positive enough to allow us to do an emergency use for our younger individuals. The new set of data that has Pfizer, so only one of the different companies, has submitted is for 5 years to 12 years. So that's a wonderful group to target because those are our school-age children. And so we'll know more after the 26th. But we're hoping that if everything that we've seen so far holds up, that we'll have a positive discussion at that point.
Thank you. And one more question for you, Dr. Gans. If kids are fully vaccinated, will they still need to wear masks at school?
Yeah, I know how hopeful people are that we're going to resume life as we know it. We are all very hopeful. Unfortunately, because there's high levels of viral transmission at this moment, including in our children populations, obviously they're not vaccinated. With the recommendation right now, because we have to be able to protect people, is to continue to wear those masks. That information, that guideline or recommendation may change as the virus changes, but really until we get our population, so we would strongly urge people to talk to friends and relatives who aren't vaccinated to get vaccinated, so we all can then go down. We need a certain level of immunity in our populations to make sure there's no viral replication. And until then, we're all going to be wearing masks.
We had a follow-up question about what we were just discussing about vaccines for kids younger than 12. Once the FDA provides emergency use authorization, how long does it take for that to translate into vaccine being available for our younger kids?
Yeah, it's a great question. So the process goes from the FDA meeting on the 26th. We make a recommendation to the FDA, who then has to decide how they want to move forward. That usually happens very quickly in a day or two. If they decide to move forward if there's a positive recommendation and they decide to move forward, then the CDC Advisory Committee on Immunization Practices meets to also make the recommendation. So there is about a 2-week gap while all this is occurring, typically before something would become available to be given to individuals.
Thank you. And this is a question for each of the representative of our different transplant programs and organs. Is there any risk of rejection of your transplant after receiving the COVID vaccine?
I guess I'll go first. So there is not. there have been scattered reports of people developing lung injury after receiving the vaccine, but it hasn't been a global phenomenon across transplanted patients, and it's only been reported in a few adults. So, and I have not heard of any complications from my colleagues in pediatric lung transplant.
Maybe perhaps Dr. Prophet or Dr. Chaudhry, you have anything to add on that?
No, there is no data that suggests there is vaccination causes, it's associated with rejection. And we have ourselves vaccinated many kids with kidney transplant. Nobody had any episode rejection of 3 doses that kids have received.
Yeah, same in heart. I mean, all of our patients have done very well with the vaccines. You know, we obviously talk about it every time we see them, and they seem to have been tolerating the vaccine well. And I have not heard of any significant side effects from any of our patients. You know, and the other complication in terms of like, could COVID disease cause rejection is that like, we won't do a biopsy if someone's COVID positive. So it does make it like a little hard, right? You wouldn't want to do an invasive procedure for us to diagnose rejection. But we haven't seen a strong signal where we're seeing lots of patients coming in with COVID infection. You know, as Dr. Gans mentioned earlier, most solid organ transplant patients are actually tolerating the virus very well. And that's been our experience here with heart, is that our patients who are positive have been fine. So we really haven't seen any association, but it is a little harder to know because of the inability to get all that data at the same point in time.
And I would add from the liver transplant standpoint about the same thing. We do have seen some temporary increase in liver enzymes around the time of COVID infection, but also again recognizing that so we generally don't go ahead with biopsies at that time. That's a known complication of COVID infection in healthy non-transplanted people as well. So we keep an eye on it, and generally we see those liver numbers get better over time, and monitor and just keep an eye on things, especially trying to make sure that folks, if they are positive, are not spending more time than necessary at the lab or out and about in places where they could infect others.
I would like to add one bit of information. In even our immunocompromised patients, there has been a fairly robust lymph node reaction in some of these patients. So, which is what we hope for. But if anybody's undergoing a scan for evidence of PTLD or anything like that, the recommendations are to wait about a month after the COVID shot, just so that you don't have to worry about it.
Thank you, Dr. Conrad. And one more question for Dr. Gans. Is there a particular COVID vaccine that you recommend, one over the Pfizer versus Moderna versus Johnson & Johnson, or is it any vaccine that is available for someone in your age group?
Well, considering the 12 to 18-year-olds only have one option, we would choose that option. And it's a great option. If you're above 18, then we would say any vaccine that's available to you, which is 3 at this moment. And just so that people know, the one that is available for children is the Pfizer BioNTech vaccine. The other 2 are called Moderna and Johnson & Johnson. We are meeting, the FDA is meeting tomorrow and Friday to decide whether or not there actually has to be additional doses of those as well. So if you did receive those, there will be more information about what is happening with that immune response. Pfizer's ahead just because they had started their studies ahead and just because they put in their data ahead of the other 2 for no other reason. That's why it's staggered this way. So you'll have more information about the other 2.
Thank you. And I think you answered this question, in the chat or in the Q&A, but I think this is of interest probably to our broader group. So if you don't mind if I bring this up to us out loud as well, do we think that children under 12 will be able to get a 3-dose series once the vaccine is available? Or do you think it will just start with the 2-dose like in older kids and then extend as time goes on?
Yeah, because the data before us is a 2-dose regimen, I think the first step will be a 2-dose regimen. But we will follow that. Excuse me. So sorry.
Sorry for directing so many questions to you, Dr. Gans. You're just so helpful.
I think we'll have to see. I'll just jump in for Dr. Gansel. I think we're just going to have to see the data. We're dose reducing the vaccine for the 5 to 12, so we're going to have to review the data. But it may make sense to do a 3rd dose, and so I think for our solid organ transplant patients, this will be a conversation as we know more in the next few weeks.
Thank you.
Thank you for stepping in there, Dr. Profito. One other question that was brought up in the Q&A so far, again, there was a written response, but I think might also be of interest to others, is has there been any discussion of, additional doses, a 4th dose or giving more down the road?
So there's no consideration yet for another dose as part of that primary series. So the primary series for immunocompromised, at least in the groups that we've looked at, the primary series now is 3 doses. So that 3rd dose is actually not a booster dose for immunocompromised as it is for the other individuals which are receiving a 3rd dose as a booster dose. So that's a little bit different process. So the recommendation for 3 doses in younger children might come more quickly, as Dr. Profeta had mentioned. The 4th dose is not part of that primary dose. There's no discussion about it being part of a primary dose right now, primary strategy right now. So we are going to have to actually follow levels long term, just like we're doing in everybody. That's the other lovely thing about this, is that it's being studied very closely over time. And so the kinetics of people's immune response, as well as what's happening in the environment in terms of viral transmission, what is in our environment, is something that's going to be followed very closely. There's also several other countries that are ahead of us that have helped us in some of our decision making. And so we're looking globally, we're looking at our own data. And so that additional dose, call it a 4th dose, or just call it an annual dose like flu. It might be that annually we all go and get COVID and flu together. So it's too early to understand all of that. Again, this is a new virus, new pandemic. We're just following it over time, but we will be ready with data when we need it to understand that.
Thank you. That is very helpful. I just want to encourage any of our participants, if you have additional questions, to please submit them there through the Q&A so that we can hear any additional questions that you have. And also, after we wrap up later, to follow up with your transplant team or any of us if you have an interest in us continuing to do events like this, if there are other things that you'd like to hear or ways that we can continue to support you through the pandemic and through other future issues that come up over time. We're always really very, very happy to have your feedback and know what kinds of things that we can do to help answer your questions, support you, and bring us all together as a transplant community.
Dr. Benson, looks like we have someone with their hand up that might want to speak. I'm going to allow them to talk, okay?
Okay.
Janet, go ahead. You have to unmute yourself though, Janet. Oh, maybe we'll come back to Janet then once we figure out what's going on there. Sorry about that.
I think I see one other additional question about, I think about flu vaccine, about higher dosing versus regular dosing in solid organ transplant. Again, we are always very happy to talk about flu vaccine as well. Another very important way of keeping our families healthy. So Haley, do you have an answer for that?
Yeah, it's a really just another really great question. We actually have put in an NIH grant for 12 institutions to look at this in solid organ transplant. So we're waiting to hear back, but there have been studies in both the adult solid organ, the adult stem cell transplant, as well as pediatric stem cell transplant that have shown that higher dose is more effective than regular dose in people whose immune systems are altered. But we can't get that indication without doing the study. So we have put in to do this in solid organ transplant. So right now, there isn't a current use or recommendation to do the higher dose. I think the good news is that we do see periodic disease in those who are vaccinated in solid organ, but again, it does seem to provide them some protection against severe disease. So for right now, that's our current recommendation.
Well, thank you very much. Just a reminder that yes, our recording will be available. It'll take us a little bit of time to post it online, but it will be available for all of you or any others in our community who are interested in listening. And I would like to pass this on to Lindsay Barkoff, who will wrap up for us.
So I just wanted to thank everyone for spending the last hour with us. And we know that, and to just acknowledge how difficult and uncertain this last, year and a half has been for all of you. We're in this with you and we totally understand where you guys are all coming from. I would say if there are 3 things that you can take away from this town hall, it's to please get the vaccine for your child who's old enough, for anyone in your household who is old enough. It'll all sort of help protect one another. Please continue to wear a mask as much as possible and socially distant as much as possible. And I would say that any mask is better than no mask. Please continue to talk to your transplant program should your child be exposed to COVID or even become sick. Like Dr. Gann said, we do have treatments that we can give. And again, we just want you to all know that we're in this together and it's our goal to keep your child safe and as healthy as possible. And don't hesitate to reach out to your transplant team with any questions.
Thank you all so much for joining us. And if there are any questions that we did not get to, please feel free to send them to us, your transplant team. And we'll do our best to always find those answers and get them back to you. And thank you so much to our panelists for sharing their time and expertise with us. Your insights are very, very helpful, and we really appreciate your time and work.
Thanks to all my colleagues, and I just am so thankful for how the families and really your commitment and devotion to your children. Thank you.